Welcome to this video on thermoregulatory centers, focusing on anatomy and physiology relevant for nursing exams. The objectives for this session include defining thermoregulation and homeostasis, locating centers in the hypothalamus, explaining heat gain versus heat loss mechanisms, understanding fever, differentiating hyperthermia from heat stroke, discussing nursing care plans, and solving previous year questions. Thermoregulation is the homeostatic mechanism by which an organism maintains its internal body temperature within a narrow, physiologically tolerable range. The normal range is 36.5 to 37.5 degrees Celsius. Core temperature refers to deep tissues, and surface temperature fluctuates with the environment. The hypothalamus, located below the thalamus, acts as the body's thermostat. It receives input from both peripheral and central thermoreceptors. It contains two specific centers, the anterior hypothalamus and the posterior hypothalamus. The anterior hypothalamus is the heat loss center activated when the body is too hot. Mechanisms triggered include vasodilation, sweating, and decreased metabolic rate. Damage here results in hyperthermia because the body cannot cool down. The posterior hypothalamus is the heat production center activated when the body is too cold. It triggers vasoconstriction, shivering, piloerection, and increased metabolism. Damage results in hypothermia, as the body cannot warm up. Let's review a previous year question. The hypothalamus acts as the primary thermostat for body temperature regulation by processing signals and adjusting heat production or loss. As a quick check, the center responsible for heat loss is the anterior hypothalamus. Mechanisms of heat loss include radiation at 60%, evaporation at 22%, convection at 15%, and conduction at 3%. Radiation transfers heat without contact, while conduction requires direct contact. Another previous year question, the transfer of heat from the body to a cooler object in direct contact is known as conduction. Mechanisms of heat production include the basal metabolic rate, with the liver being the hottest organ. Muscle activity, such as shivering, significantly increases heat. Chemical thermogenesis involves hormones like thyroxine and epinephrine, as well as dietary thermogenesis. Non-shivering thermogenesis relies on highly vascular brown fat, which metabolizes directly to create heat. This is especially important for newborns and premature infants who lack the ability to shiver effectively, putting them at high risk for hypothermia. A question on neonates. The primary mechanism for thermoregulation in neonates is non-shivering thermogenesis, or brown fat. The pathophysiology of fever begins with pyrogens from infection or trauma, leading white blood cells to release endogenous pyrogens. These stimulate prostaglandin synthesis in the hypothalamus, resetting the set point to a higher temperature. The body then initiates heat production to reach this new setting. Fever has three stages: onset or chill phase, where temperature rises with shivering and pallor; fastigium or plateau, where the set point is maintained; and defervescence or flush, where the temperature drops back to normal with profuse sweating and vasodilation. During the onset phase of fever, when the patient feels cold, the appropriate nursing intervention is to provide warm blankets to reduce shivering as the body attempts to raise the temperature to the new set point. Differentiating fever and hyperthermia is key. Fever involves a raised set point and is treated with antipyretics. Hyperthermia involves a normal set point, results from failed thermoregulation, and requires physical cooling as antipyretics do not work. Heat stroke is a medical emergency defined by a core temperature over 40 degrees Celsius with CNS dysfunction. The cardinal sign is hot, dry skin, as the sweating mechanism has failed. Management requires rapid cooling to drop the temperature to 39 degrees Celsius. The clinical finding that best distinguishes heat stroke from heat exhaustion is hot, dry skin, or anhidrosis, indicating the failure of the sweating mechanism. Malignant hyperthermia is a genetic reaction to general anesthesia, causing massive calcium release leading to muscle rigidity and extreme heat. Early signs include jaw rigidity and high carbon dioxide. The antidote is dantrolene sodium. The drug of choice for treating malignant hyperthermia is dantrolene sodium. A tepid sponge bath is indicated for fever above 38.9 degrees Celsius not responding to medication. Use lukewarm water and apply wet clothes to the axilla and groin. Stop immediately if the patient starts shivering, as this increases temperature. Hypothermia is a core temperature below 35 degrees Celsius. Severity ranges from mild with shivering to severe, below 28 degrees Celsius, where coma occurs. A significant clinical risk is ventricular fibrillation if the patient is handled roughly. Rewarming techniques include passive external for mild cases, active external using devices like a bear hugger for moderate cases, and active core methods like warm IV fluids for severe cases. When rewarming a patient with severe hypothermia, the trunk is warmed before the extremities to prevent afterdrop hypotension and dysrhythmias. Reviewing temperature assessment sites is essential for accurate monitoring. A key point regarding temperature measurement is that the rectal site is contraindicated in a patient with myocardial infarction due to the risk of vagal stimulation. Antipyretics work by inhibiting prostaglandin synthesis. Acetaminophen is the drug of choice for children, while aspirin and NSAIDs are generally avoided in children with viral fever due to the risk of Reyes syndrome. In a case of heat stroke, priority nursing actions include maintaining ABCs, rapid physical cooling, providing IV fluids, and monitoring for shivering, giving benzodiazepines if necessary. For moderate hypothermia, priority actions are gentle handling to prevent VFib, active external rewarming, cardiac monitoring, and administering warm IV fluids. Relevant NANDA nursing diagnoses include hyperthermia, hypothermia, ineffective thermoregulation, and risk for deficient fluid volume related to changes in metabolism or sweating. Golden points to remember. The hypothalamus is the thermostat. Anterior hypo manages heat loss, and posterior hypo manages heat production. Most heat is lost via radiation, and neonates rely on brown fat. More golden points. Rectal temp is the most accurate core temperature, but contraindicated in cardiac cases. Heat stroke has hot, dry skin. The antidote for malignant hyperthermia is dantrolene, and avoid aspirin in children. In summary, thermoregulation is a vital homeostatic function controlled by the hypothalamus. Understanding the balance between heat loss and heat production enables effective nursing management of fevers, heat strokes, and hypothermia. Thank you for watching this video. Best of luck with your exam preparations.